My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and the topic of this Learn and Share conference call is Diagnosis and Management of Psychogenic Nonepileptic Seizures. And we're very fortunate to have with us today a panel of speakers from the University of Michigan Health System. We have Dr. Nicholas Beimer, who's an epileptologist, Dr. Scott Winder, who's a psychiatrist, Dr. Elissa Patterson, who's a health psychologist, and Najda Robinson-Mayer, who is a clinical social worker. And they all work together as a team at the University of Michigan Health System. So welcome. And could each of you just briefly introduce yourself and give an overview of your experience with this particular topic?
Sure, I'll start. This is Nick Beimer. I'm a epileptologist, as you said, Russ, training as a neurologist as well. I did all of my training essentially here at the University of Michigan. I was a resident and clinical neurophysiology fellow. I've been on faculty here for about a year. And my experience has been mainly through my training with faculty mentors that have an interest particularly in the diagnosis, as well as in the last year, some specific training that I've done in learning a particular type of cognitive behavioral therapy informed psychotherapy with someone named Kurt LaFrance, who's a professor, neurologist, and psychiatrist at Brown University in Rhode Island.
Great. Dr. Winder?
So this is, this is Scott Winder. I'm a psychiatrist. I did my residency in general psychiatry here at the University of Michigan and then stayed on for a year fellowship in psychosomatic medicine, which is the psychiatric care of the medically ill. It's a one-year boarded fellowship, and it's the basis for training consult psychiatrists who work in the hospital and elsewhere who are very much in the trenches with other teams of physicians looking at mental health contribution and causes of various medical and behavioral phenomena in the health system, and that's what led me to spend some time with the epileptologists. I have a distinct interest in neurology, I always have, and spent a month with the epileptologist here during my fellowship. That's where I met Nick Beimer and found him to be a very psychologically and holistic-minded neurologist and was really impressed with him. And then when his career aspirations became clear and he was interested in pursuing this patient population, I forced him to let me, help him out with it. And my experience with the disorder has been throughout my residency, throughout my fellowship working in the hospital, but also, as you all know, through a psychiatric residency, we're trained in cognitive behavioral therapy, skills-based therapy like dialectical behavioral therapy, interpersonal therapy, psychodynamic therapy, and so coming at it from a behavioral standpoint was intuitive for me given my training.
Great. Dr. Patterson?
Sure, yeah. So I am a health psychologist. I trained in Chicago and then in Boston, and my interests have been with disorders that involve both the mind and the body. So I worked in a primary care outpatient clinic and a neurology clinic when I was in Boston. So I would come across folks who have issues similar to non-epileptic seizures and would start to do therapeutic psychological treatments with them in Boston during my training. And then when I arrived here in Michigan about 2 years ago, I have been developing a specialty in treating this type of patient. And with Dr. Beimer and Dr. Winder and Najda, I am working on the same, using the same protocol, taking control of your seizures, the workbook written by Kurt LaFrance, and using that to do outpatient therapy with patients who have been diagnosed with psychogenic nonepileptic seizures. I'm also acting as the liaison in the hospital when folks are initially diagnosed with nonepileptic seizures so that they can get an introduction to our clinic and the process.
Excellent. Najda, can you introduce yourself?
Yes, I'm Najda Robinson-Mayer. I'm a licensed clinical social worker and have been working in the epilepsy clinic at U of M for the past year. In my work, I meet with both patients who have epilepsy as well as patients who have the psychogenic non-epileptic seizures. And I've been working with this team with Dr. Beimer, Dr. Winder, and Dr. Patterson for this past year and getting more involved with a specific population. And eventually, one of the goals is for me to be able to provide some therapy to patients with this.
Great. Okay, well, let's start with definitions. What are psychogenic non-epileptic seizures, and equally importantly, what are they not?
This is Nick Beimer. I'll take this one. So a good definition would be that a psychogenic non-epileptic seizure is an episode that involves any kind of abnormal appearing movement, sensation, or really experience by the person that's really distinct from an epileptic seizure. The distinguishing feature is that when you use testing, and we use EEG monitoring to diagnose epileptic or non-epileptic seizures, the psychogenic non-epileptic seizures do not have an abnormal electrical brain activity noted on an EEG. So there's important distinctions there. Psychogenic non-epileptic seizures are not epileptic, meaning they're not epilepsy. Epilepsy is a separate diagnosis. But there's some common misconceptions about what psychogenic non-epileptic seizures are. And one thing that they are not is that it's not faking. It's not what we call sometimes malingering, meaning there is no thought that patients are making these things happen intentionally. For them, the experience is very much the same as, in fact, having an epileptic seizure, but the distinction is that there is no abnormal electrical activity in the brain when the event actually occurs.
Okay, great. And we'll talk more in a second about causes and more about the nature of psychogenic non-epileptic seizures. But I wanted to briefly touch on terminology. It's highly variable regarding psychogenic non-epileptic seizures, and there's a fair amount of debate surrounding this. Can you talk about some of the older terms that were used and are still unfortunately used by some today, and then also the debate over what the current terminology should be used?
Sure. So the older terminology, there's actually quite a few different terms that you might hear still. One of the most common ones that we don't use anymore is pseudo-seizure. Pseudo, that portion of the word means false, and so there's a misconception there about calling a seizure a false seizure. It can imply, as I had already stated, that it's something that's not real or faked, for example, which is not what a non-epileptic psychogenic seizure is. There's other terms that have been included too, such as a hysterical seizure or hysteria. That's an even older term. It's almost not used whatsoever nowadays. Spells is another one too, in fact, and that's probably one that's most commonly still used and has fallen out of favor as a term that's used to describe a psychogenic non-epileptic seizure. The word spell is obviously very nondescript. It doesn't describe very well what's happening. It just signifies something that's happening episodically. And so one of the most favored terms that is used in literature now, when you look at publications that researchers write about this condition, is that of a psychogenic non-epileptic seizure, in fact. And there are other words that people use to replace the word seizure, event or attack. I don't personally have a problem with the replacement of those words. That really is a description of just an episodic symptom that happens, and the more important part of the terminology is psychogenic non-epileptic. Others might disagree about that with regards to calling psychogenic non-epileptic seizures, specifically using the word seizure because of the distinction between an epileptic seizure and a psychogenic non-epileptic seizure, but personally I don't find problems with it. That's where maybe some of the controversy still lies in how you use the terminology correctly.
Right, okay. So the term non-epileptic seizures, which is sometimes used to refer to psychogenic non-epileptic seizures, sometimes that the more broad term non-epileptic seizures may be used, and one of the problems is that it can include both psychogenic non-epileptic seizures and physiologic non-epileptic seizures. Can you talk or briefly list some of the conditions that can fall under the category of physiologic non-epileptic seizures?
Yeah, so among the physiologic non-epileptic type, and I personally usually use the term physiologic non-epileptic event because this is actually where there is a distinction in a seizure versus something that is not. Right. And as an example, fainting. So the medical term that we use is syncope. And so fainting can often appear to look very much like a seizure of any kind, epileptic or psychogenic non-epileptic. And the reason is that you can have jerking that occurs in up to 80% of people with fainting spells. And so that can be confused. But it is actually very similar in what it looks like, but it is very different in what it's caused by. So fainting from things like changes in blood pressure or heart rate. Other conditions, again, that you would call physiologic non-epileptic events that are not the same but are still non-epileptic would be things like tremor or a REM behavior disorder, such as like a sleep disorder, periodic limb movement disorder with sleep. Another one would be cataplexy. Cataplexy is a condition where one falls suddenly, loses tone, but doesn't have an alteration of their awareness or consciousness that can be associated with other conditions like narcolepsy, for example.
Okay. So what are the possible causes of psychogenic non-epileptic seizures, and who's most likely to experience them?
So there's quite a few causes, and there are a few things in particular that we know are associated with the diagnosis. So we know that, in fact, anywhere from 70 to 100% of people with psychogenic non-epileptic seizures have endured some kind of trauma in their lifetime, and the trauma can be of various kinds, but the most common kind are either physical trauma, such as abuse or being hit or neglected, or in fact sexual trauma in some way. So that means a history of being raped or touched inappropriately or unwantedly, and also very commonly diagnoses of post-traumatic stress disorder is commonly found. In children, and not in adults necessarily, but possibly in children, there's a very worrisome association of ongoing abuse that's happening when the diagnosis is made. When people are most likely to experience them, it happens predominantly in women, about 3 to 1 women, so that's about 70% of patients are women, often coming on in lifetime between the ages of 15 and 35. So that's the most likely period of time.
Okay. And you mentioned traumatic events, and we'll talk later about the association between epilepsy and psychogenic non-epileptic seizures. Is having a seizure in public, or is that ever traumatic enough to be considered an event that is the basis for the development of psychogenic non-epileptic seizures, or maybe not a single seizure, but repeated seizures in public that are, psychologically traumatizing?
I would wonder that, yeah. I think that seizures by themselves, if we're talking about psychogenic non-epileptic seizures, or if we're talking about epileptic seizures, they're very frightening. Excuse me. They are often depicted in movies and on TV somewhat dramatically. People have commonly see them because epilepsy affects a large number of people in our population. Up to 1% of all people actually have a diagnosis of epilepsy at some point in their life. And so I think that it is traumatic, and that experience can be traumatic. I would wonder about that relationship. I would wonder and wouldn't certainly want to dismiss the possibility that there could be other things related to that experience, but I would also agree that that's possible.
Okay. So how are psychogenic non-epileptic seizures classified in the DSM-5, which is the Diagnostic Manual for Psychiatric Conditions?
So this is Scott Winder. For those who aren't familiar with this, this is sometimes called the Bible of psychiatry, and it's an evolving sort of dynamic document that is in its 5th iteration and is rightfully criticized because it is a categorization of human behavior, and it does not engage with the biological substrate of what's causing the condition itself. And so in mental health, and I think this is important, as just a general topic at the interface between neurology and psychiatry, that this discussion about cause versus categorization will persist throughout our entire career, but there are efforts within mental health, many that were very public on the pages of the newspaper, in the major newspapers, about this argument about what is causing versus how to categorize and sort of sort people's symptoms. And so that's the basis of what this is. And so when you look at the actual classification for non-epileptic seizures, it exists under a more general umbrella of a conversion disorder. The verbiage is dated. Conversion refers back to the Freudian days where somebody's psychological distress was converted into a physical manifestation. Like everything in our evolving vernacular, this was highly scrutinized, and terminology is so important. And so you might expect that this term would have gone away. But this is one of the few that has persisted, that neurologists and psychiatrists still find this a valuable term to describe what happens to people who have unexplained symptoms. Now, they did add a secondary name, which is functional neurological symptom disorder, that's in parentheses. And to point this out, you only need to look at the criteria themselves to see that this is a broad array of conditions: weakness, paralysis, abnormal movements, swallowing symptoms, speech symptoms like dysphonia or slurred speech, sensory loss, changes in the visual, olfactory, or auditory systems. But yet attacks and seizures do appear there. And so that it's a segment of a particular diagnosis in the DSM. It does, being a categorization system, it does have A, B, C, and D, like you would expect. And so it does require that the patient have one or more symptoms of altered voluntary motor or sensory function, again, speaking generally. And the most important one is criterion B, which requires that the symptom itself be incompatible with recognized neurological and medical conditions. And this distinguishes it from other so-called somatic symptom disorders that are categorized in this same section in the DSM. It's unique because of how we locate and model the etiology of neurological symptoms. We can say with some certainty that a particular symptom crosses a dermatome or doesn't map to how we know the nerve pathways are in a person's body. And so I would draw out that incompatibility piece when we think about the DSM classification. And as you see throughout the DSM, it's criterion C, where it can't be better explained by another medical or mental disorder. That's frequently stated. Much of this is a diagnosis of exclusion. And criterion D is also very predictable, very common, and very useful in that it requires the patient to experience significant distress or impairment in multiple domains of their life. And we do see patients who aren't bothered by this, but as everybody on the call knows, that the reason why they present is because this is causing a significant problem. So those are the general features of how psychiatry comes at this particular disorder.
Okay, great. And how does this differ from, how does conversion disorder differ from factitious disorder or malingering, which was mentioned earlier?
So there's a concept here of secondary gain. Factitious disorder is a psychiatric diagnosis. It does appear in the DSM, and it depicts an individual who's falsifying physical or psychological symptoms or an injury or some other condition that is being willfully caused. The patient presents themselves as being ill, impaired, and injured, and the circumstances under which they're presenting are devoid of secondary gain, meaning the team evaluating them can't see any quote-unquote reason why they would be behaving this way. And again, that this isn't being explained better by another mental condition. And so the secondary gain piece is what this distinction between factitious disorder and malingering turns on. We see patients in the hospital who cause their own illness, who present health system after health system and even travel sometimes from place to place as if they are professional patients. Yet there's no benefit to them for why they do this. There are some psychological theories that I don't think would be helpful necessarily to go into, but that this is a motivated behavior, but there's no sort of monetary or occupational benefit for presenting this way. And then to move to malingering, this is not a psychiatric condition. Contrary to what happens in a hospital multiple times, just because somebody is intentionally feigning their symptoms doesn't mean that they have a psychiatric illness. And I'm sure all of us know of cases where in order to get some time away from work or in order to get a disability compensation or to force retirement or any number of circumstances, a person would intentionally cause their own illness. And malingering can be criminal, but it does not have a basis necessarily in a mental health diagnosis.
Okay, and the important point here is that psychogenic non-epileptic seizures do not fall under either of those two conditions.
Right, right.
So how prevalent is, would you say, the bias in the medical community is where professionals sort of put psychogenic non-epileptic seizures and malingering in that same category? I've certainly heard multiple stories of patients being told that they're faking their seizures or to just get over it, or just being told, I can't help you, these aren't real, that type of thing. How prevalent do you think that is, and then also why is it harmful, and what needs to be done to eliminate this bias?
Yeah, so we on our team, we talk a lot about dualism, and this is an unfortunate artifact of past centuries where the mind and body are seen as very, very different. But in reality, as we know, and a more sophisticated approach to human beings suggests that the links between mind and brain are, they're inherent, they're fundamental, and by extension of the brain being a part of the key, obviously stating the obvious, part of the body, the mind is very much connected to the body. The name of my fellowship of psychosomatic medicine, psycho, mind, soma, body, really embodies more contemporary efforts to try and bridge this gap. And Dr. Patterson certainly is very thoughtful in how she enunciates this to patients, and I think we all strive to make that link. Unfortunately, in the medical community, this is an allopathic, most of us are allopathic physicians, some of us osteopathic, and osteopathy tends to concentrate more on this. But allopathic physicians tend to focus on what it's not, a differential diagnosis, an exclusionary process that has its merits. But one of the unfortunate side effects is that patients like non-epileptic seizure patients are told what it isn't. And by extension, doctors, we can be very narcissistic. And when we don't know or don't understand why a patient would behave in a certain way, we naturally and sometimes superficially assume that they must be causing it. And then there can be blame. This is where this construct in psychiatry of countertransference becomes very informative. Countertransference meaning how we transfer our feelings onto the patient in front of us. And so many times neurologists and other physicians, even psychiatrists, can be frustrated and accusatory towards these patients. So it's very harmful in a few ways. One would be because it propagates and perpetuates this false dogma that the mind and the body are two different things, and they're not. They're very much connected, and one only need look at the very normal everyday process of being embarrassed, having an event take place in our environment, and how we respond with maybe increased sweating and our heart rate going up and our face turning red. If we're critical, what does our face turning red have to do with being embarrassed? It's just an emotion. I mean, when we really look at normal everyday symptoms, we see intuitively that they're very much linked. And when neurologists, and we're lucky here at the University of Michigan, we have some neurologists, even apart from Dr. Beimer, who are very sophisticated in how this is depicted to the patient. It can be quite comforting to them to realize that this is real, that their experience isn't voluntary, that this is happening to them and they can't understand, and to approach it in that way, to give them examples like being embarrassed or being nervous that are intuitive to them, that they have experienced, and to challenge them and say, what does your face turning red have to do with being, embarrassed or making a left turn when you shouldn't have or something? What does your face turning red have to do with that? The patients respond in such a favorable way to this that it really can be a needed bridge to the future behavioral and therapies and paradigm shifts that have been proven in the literature by LaFrance and others to decrease the seizure frequency and to increase their functioning. But without this key piece that Russ has sort of couched this question in of striking down and rejecting these antiquated stereotypes and instead moving towards a more thoughtful, holistic, and sophisticated approach to people's experience, we're not going to be able to take as good a care of these patients as we need to.
Great. So what other psychiatric disorders are associated with psychogenic non-epileptic seizures? I know Dr. Beimer mentioned post-traumatic stress disorder. That's certainly one to talk about. Are there others?
Sure. There are, and intuitively, this population is burdened with a lot of psychiatric comorbidity, and the literature generally suggests that the degree or severity of psychopathology correlates in a positive way with the severity of the non-epileptic seizure. So, as you're implying, Russ, that we do care very much about what else is traveling with the PNES diagnosis. What we generally find is that 90% of patients, and it depends on what you read, but generally 90% of patients with this diagnosis report significant traumatic experiences in their past. And of course we might say things about recall bias and all of that, but the numbers of 35 to 50% of patients meet full criteria for PTSD shows that this is a heavy comorbidity. And the onset of the PNES phenomena may or may not be associated temporally, chronologically, with the actual trauma. Sometimes this can happen in a protracted manner years after. And I experienced some profound experiences on 4A on our long-term monitoring unit where patients had never disclosed that this had happened until one of our neurologists went into this part of their life in a very eyes-open fashion to discuss what this stress reaction might be. Panic disorder is very prevalent. And panic, I mean, we could list criteria, and I don't think that would be as helpful, but generally panic disorder, panic attacks are short periods of intense anxiety that are accompanied by a whole burden of somatic symptoms and can create themselves significant anxiety about going to a place or experiencing this level of distress, and it can lead to highly avoidant behaviors. And in patients who've been traumatized and who've been, as you pointed out earlier, Russ, in a public setting where they might have been humiliated in this way, it's not hard to see that panic is something that we frequently encounter. Anywhere from half to three-quarters of patients suffer from a depressive disorder. And again, the criteria focus heavily on mood, ability to feel pleasure, thoughts of suicide, appetite, sleep. I think everybody's relatively familiar with what major depression is, and this is a frequent comorbidity. The personality profile of patients with PNES is unfortunate because personality disorders are hard to treat. They're poorly understood, and most damaging, they're very, very stigmatized. Borderline personality disorder it seems to be nowadays more like a judgment or a disregarding statement than a diagnosis, which is inevitable but unfortunate. The largest group of patients with PNES with personality struggles seem to be in this cluster B borderline personality disorder category. Some studies have put it as high as 70% of patients with PNES fulfill past criteria, DSM-3 or DSM-4, for a personality disorder. So this is a challenge, and for modern medicine that wants to treat people and discharge, personality disorders are a challenge throughout the health system. But in this particular population, it is an unfortunate comorbidity. There's some fascinating stuff about dissociation in trauma victims. There are a cluster of dissociative disorders. Dissociation is frequently conceptualized as the body's response to sort of quarantine severe stress and horror. And so it's not hard to see that as many as 91% of patients in some studies have dissociative symptoms with their PNES, the diagnosis. And many people conceptualize the seizure itself as is like a dissociation. And the last one I would bring up for everybody's consideration would be the so-called somatic symptom disorder, which immediately precedes conversion disorder in the DSM-5. I would remind everybody what I mentioned earlier about the incompatibility clause when it comes to conversion, meaning know that this doesn't follow neurological principles. Frequently, the way patients present with somatic symptom disorder involves more general and hard-to-prove phenomena. What I mean by that is like fatigue or pain. These are things that you can't necessarily disprove like you could with a particular sensory deficit or motor deficit. And somatic symptom disorder is rife with persistent thoughts of anxiety, significant time and energy devoted to the symptoms themselves, and that really do amount to a significant amount of distress and disruption of daily life. You can have both. It's not hard to see how that could happen. But when you have a neurological component that you have a confidence is not biologically based in the traditional sense, you can distinguish between these two diagnoses. Russ, one more thing, I apologize. I wanted to mention that psychosis, substance use disorders, and alcohol disorders are uncommon. So that I've told you kind of what is there. We don't see those diagnoses in this population.
Okay, interesting. So when we talk later about treatment, I'm assuming then treatment is often more than just dealing with the PNES, but you may be having to deal with multiple psychiatric disorders as well.
Yeah.
Okay.
And that's why I'm on the team. Yep.
Right. So now let's talk about PNES as it relates to epilepsy. So I've read that about 15% of patients with PNES also have epilepsy. Do you know the percentage of people with epilepsy who also have PNES?
Yeah, so this is Nick Beimer again. It's actually a very similar percentage, in fact. So studies have suggested anywhere from 5 to 20% of people with epilepsy also have psychogenic non-epileptic seizures. So that kind of goes along with your question, Russ, earlier about, are epileptic seizures and the experience of having a seizure a significant traumatic thing in and of itself? I think that number actually suggests that it is, and that's where I wonder, about the frequency of it in patients with epilepsy too.
Right. And one thing, going back to cause that I wanted to follow up on, obviously trauma seems to be the most common cause, but to what extent is just current stress, just if you're under a high level of stress, can that also be a cause in the absence of trauma?
I think so too, yeah. And we didn't elaborate much earlier about, the definitions and the other causes of psychogenic non-epileptic seizures, but perhaps just a simpler description that I think of when I talk to my patients about this diagnosis is that it's really any psychological conflict in your own mind that can lead to physical symptoms, and that could be dealing with the trauma that happened a long time ago, but it may be dealing with something that's happening to you now, and it doesn't necessarily have to have been a traumatic thing in and of itself. It could be a combination of life stressors that are happening. In general, as human beings, we're quite resilient, and we deal in the human condition with lots of stress. Stress is a normal thing, and I sort of worry a little bit about just saying, psychogenic non-epileptic seizures are just due to stress, because sometimes that in and of itself comes up, negatively when it's communicated to patients. Again, they hear that you're saying you're just making it up, it's faking. That's clearly not what it is, as we've talked about, but it's true that just kind of stressors day to day, if you have enough of them pile up on each other, I do think that that's a reasonable enough cause too.
And can you briefly talk about the distinction between stress as a cause of psychogenic non-epileptic seizures versus stress as a trigger for epileptic seizures?
Sure. So I think that both are true. We know that patients with epilepsy, in fact, the number one cause or trigger of their seizures when they have epileptic seizures they cite is stress, in fact. And so that's a known documented thing in epilepsy patients. Separately, though, in patients with psychogenic non-epileptic seizures, the concept of stress could not only be the trigger at the time, similar to patients with similar to patients with epilepsy, but it could also be part of the responsible factor in the first place, the reason why they have the non-epileptic seizures themselves.
Right. Okay. I've also read that anywhere from 20 to 30%, or sometimes even higher, of patients referred to comprehensive epilepsy centers actually have psychogenic non-epileptic seizures. And also the average time to diagnosis of PNES is 7 to 10 years. So clearly misdiagnosis is common both ways, either PNES being misdiagnosed as epilepsy or vice versa. Let's talk about the different tools that can be used to diagnose PNES and the strengths and limitations of each. So let's start with the patient history, which is clearly important. You get a lot of information through that, and one of the biggest things you're trying to get at is what are the different symptoms that are experienced during this event or this suspected seizure. So both epileptic and non-epileptic seizures can feature a wide range of symptoms, but there are certain symptoms that are highly associated with either epilepsy or PNES. Can you talk about those symptoms that are most useful in differential diagnosis?
Yeah, so in terms of distinguishing the two different types, epileptic versus psychogenic non-epileptic seizures, there's a number of different signs that people have looked at. So one, and just we'll go down a list of them. One is eyes being open or closed during a non-epileptic seizure are more likely, in fact, patients have their eyes closed. They often resist their eyes being opened, whereas a patient with epilepsy and epileptic seizures more likely has their eyes open already, in fact, during their seizure. The pupillary light reflex, when a doctor shines a light in your eyes and looks for how the pupil responds, is commonly present in non-epileptic seizures, while it's not present in epileptic seizures. Psychogenic non-epileptic seizures, patients often cry or weep at some point during or after the end of the event itself. In an epileptic seizure, it's more common that people can have an unusual sort of wail or scream that precedes or starts the seizure, but not during or afterwards usually. There can be changes in speech patterns. So epileptic seizures, patients can often have trouble speaking afterwards. And while that may also be true in non-epileptic seizures, the speech pattern is usually distinct in other ways, such as stuttering. So stuttering is more often found in non-epileptic seizures. Psychogenic non-epileptic seizures can have physical symptoms like thrusting, like pelvic thrusting or back arching, whereas it can happen in epileptic seizures, but it's not quite as common. Head shaking or the actual movements of the body, the convulsions themselves, are usually more synchronized in epileptic seizures. So they are, meaning to say, if there's rhythmic jerking of the arms or the legs, they usually happen at the same time both on the left and the right side of the body in epileptic seizures, where in non-epileptic seizures they often are not synchronized. So one side is moving and the other side is moving at its own pace or rhythm. Head shaking, so left-right, as if you're saying no or shaking your head vigorously, is more often seen in non-epileptic seizures, whereas the head being turned one side or the other consistently is usually part of an epileptic seizure. And then probably one of the most helpful things is that non-epileptic seizures tend to kind of wax and wane. They stop and start. So the jerking or the shaking or the stiffening can happen on and off and on and off over a period of time. The average length of time for an epileptic seizure is on the range of, less than 2 minutes, whereas non-epileptic seizures are often much longer. It'd be very unusual for an epileptic seizure to last longer than 5 minutes. It does happen, but it's just much less common.
Okay, great. So it seems like that's very helpful, but I would guess that few of any of those symptoms are 100% predictive. So with that in mind, should a diagnosis ever be based solely on those symptoms? And can you ever think of a case, an example, where you were sure based on multiple symptoms that the seizure was either epileptic or non-epileptic, only to find out later that they were the opposite of what you thought?
Yeah, you're definitely right, Russ. It's very much a mistake to assume that any one or even a set of those things together is absolutely certain for what type of a seizure it is, epileptic or non-epileptic. And so, no, you can't use any of them absolutely, but those are the common things. You cannot use just the clinical features, the symptoms that we talked about just now to diagnose. That's not the best way. And in fact, I admit there are many times that I, hear about what the seizure sounds like from a description from the family or the patient themselves, and I already am trying to determine in my mind whether or not I think the likelihood is that it's epileptic or non-epileptic. And I definitely admit there are many cases in which I think, based upon the description, that it's going to be one, and it turns out to be the other. And it's happened both ways. I've been disproven in thinking that someone had likely non-epileptic seizures and they turned out to be epileptic. And I've also been disproven the other way, where I thought for sure that someone was having epileptic seizures and they turned out to be non-epileptic. And actually, if you look at the literature, they did a survey, and they assessed the ability of trained epileptologists like myself, so neurologists that has specialized training in epilepsy and seizures, as far as how accurate they were at correctly making a diagnosis only based upon the clinical symptoms, so what they saw like on a video, and they were only right about 72% of the time. So that means that they were wrong in nearly a third of the patients, and these are supposedly the experts, right? No one else in the world should know better than them, and they were only right, they get a C- on their score. So it explains how important it is to use other types of testing.
Right. So let's talk about, well, before we move away from the patient history, is there other information besides seizure symptoms that you get during the patient history that can be helpful in making a diagnosis?
Yeah, I might ask maybe Dr. Patterson to comment on some of these things.
Sure, yeah. We will gather information that helps us understand the particular circumstances of each patient, and we do this because there are, of course, common elements among patients with PNES, but each person experiences PNES differently and their life circumstances may be different. So learning more about each individual can help dictate the elements that we focus on in our treatment. For example, for some people, as has been mentioned both by Dr. Beimer and Dr. Winder, for some people traumatic life events are involved, and we will sometimes see that there are certain circumstances or events happening in current day life that are related to those past traumas, and those triggers can sometimes be triggers for PNES. So we will work with patients to learn more about those circumstances and try to address those issues. And often we do that in the early stages as we're getting to know the folks we're working with. For example, if someone has a neighbor who is abusing a child and perhaps the patient, him or herself, was abused as a child, this could be a trigger for a psychogenic non-epileptic seizure. And as Dr. Beimer mentioned, also stress or sometimes complex emotions that are difficult to express, those are believed to be a large component of PNES. And we can't know this until we get to know the individuals that we're working with. So we'll then also look for strengths that the individuals have so that we can help people build on their strengths and help them figure out ways that they can cope with some of these challenges so that they're not experiencing them as the PNES symptoms. Okay, so we'll sometimes, yeah.
Great.
But I think that covers the gist of it.
Okay. And something that was used, at least in the past, and I'm not sure the extent to which it's still used, are serum prolactin levels and other blood tests. Due to the lack of sensitivity, I'm not sure, are those tests still used, and are there any situations where they might be used?
Speaking on this, as an epileptologist, I never use it personally. Okay. I do see sometimes patients who come into the emergency department whom have the test drawn by, the emergency department physician. Historically, though, the sensitivity, even in epilepsy, is quite bad. So the problem is that even if it's bad for patients with epileptic seizures, then if it's negative, it doesn't really tell you much about if it's epileptic or non-epileptic in a patient that could have non-epileptic seizures. The sensitivity, for example, in someone with a generalized epileptic seizure is only about 60%. So that means you're missing almost half of them in that case. Right. And in patients with epilepsy with complex partial seizures, that's kind of an old term nowadays, but a seizure where they don't necessarily convulse, but they are unconscious or unaware, the sensitivity is less than 50%. Right.
Okay. So really the gold standard for diagnosing PNES is video EEG monitoring. Can you talk about how this is used, and then also talk about some of the limitations of video EEG monitoring?
Yeah, so it's used very commonly. We of course do it here at the University of Michigan and many academic medical centers and some smaller community centers have long-term EEG monitoring as a means of diagnosis. It's fairly straightforward. Patients are admitted electively to the hospital, so they figure out a time that works well for them. We always ask patients to have their family or friends or someone who knows what their events look like come with them and stay with them in the hospital. They get hooked up to an EEG, just like they may have had done, as an outpatient in the past, except for instead of lasting for just 30 minutes or an hour or two, they stay on the EEG for hours and days until we actually record with the EEG and a video running at the same time one or multiple of their typical events. And we look at the brain waves during the symptoms, we look at them in between, and all of the above are used in determining the diagnosis. The limitations, kind of speaking to that, it's a far from perfect test. There are no perfect tests in medicine. And it's true that you can have a lot of artifacts. So we talk about artifact meaning things that are picked up with the EEG that may not necessarily be brain waves, for example. Things like muscle activation, like strain in the temples or neck can come up on an EEG. Heart rhythm can be sort of shining through on an EEG. Movement itself, so just rubbing the head or moving around in bed, blinking or chewing or talking, can all sort of make it difficult to read what the brain waves are. And so those are some definite limitations. And in addition to that, there are some types of epileptic seizures, in fact, so the type of seizures that are epilepsy and are due to abnormal electrical activity in the brain that don't show up on an EEG. And the common types of seizures are, for example, frontal lobe seizures, or any seizure really in which a patient experiences something, and they believe that they're having their seizure, but yet they have retained awareness or consciousness. It often is the case, in fact, that you cannot see any abnormal change on an EEG because when we measure with an EEG, we measure large areas of surface of the brain, and if not enough of the brain is involved in an epileptic seizure, then you may not see it come up on the EEG itself. And so we look at certain features of what happens to people during a seizure, and we have to determine, based upon what we see on the video, if we would expect to see a change on the EEG. If we don't think that we could see a change on the EEG based upon what happens, then we have to be very careful and say that although we may not have seen an abnormal change on the EEG during that patient's typical event, we have to qualify and say that it's possible that it is an epileptic seizure if it was of a certain type. And so it's not a perfect test. There are other types, though, and the ones that we talked about where people lose consciousness and they have very significant body shaking. We're quite confident that we would see something abnormal on an EEG in that case. And when we don't, then that's when we're quite confident in the diagnosis of non-epileptic seizures.
Right. And frontal lobe seizures are further complicated by the fact that the symptoms can be rather unusual and not what you typically think of an epileptic seizure. So that can involve screaming or flailing, asynchronous movements and things like that. So that has to be pretty challenging.
Yep, that's correct, yep.
And then what about the situation where, because we talked about some people have both epileptic and non-epileptic seizures. What if someone comes in and they happen only to have non-epileptic seizures during their stay, but it turns out they actually have epileptic seizures as well, but they just didn't have one during that brief window of time that they're in the monitoring unit, or vice versa?
Right. So that's one of the things that we always focus on when patients are, going to the trouble of, allowing us to watch them in a hospital for several days. If they have more than one symptom or event type, we want to see every type. We can only really comment on the types that they have during the test and not really on the ones that they don't have. So if they have 3 types of seizures and we wonder could they have epileptic and non-epileptic seizures, if we only see 2 of the 3 types, we can say, within the certainty that we can about those 2 types, and then the 3rd type, it has to remain a possibility that it's epileptic or non-epileptic, and we can't really say much until we could see it too.
Right. So where is the diagnosis, or who typically makes the diagnosis of PNES? Is it typically an epileptologist? Is it sometimes a psychiatrist? Is it sometimes a psychologist?
Here at our facility, it tends to start, and rightfully so, with neurology, because as you recall with the criteria that I listed from the DSM, this diagnosis would have to be not better explained by another condition. And so I think it's really important that the neurologists oversee that. But psychiatrists and psychologists, we can be helpful when patients' beliefs or their conception of their illness, their coping strategy, the psychiatric history we've already talked about, their family dynamic, or just their general interpersonal style become relevant either to the diagnosis and or the treatment planning. And sometimes we can help our neurology colleagues with ways to phrase and talk about what this illness is, avoiding things like there's no physical cause or this is all in your head, or help to manage patient confusion and anger that might result from talking about this. So I think there's a very supportive role for mental health, but I think in our facility and in my conception of how this is managed, starting with neurology is really important.
Right. Okay. So when someone has been treated for years as having epilepsy and then finds out that they actually have psychogenic non-epileptic seizures, what should ideally happen in terms of presenting the diagnosis and then transitioning them to appropriate care?
So ideally, it's best if a neurologist presents the diagnosis of PNES so that the individual can ask whatever medical or neurological questions he or she has. It can obviously be very frustrating for people to realize that they were treated for a condition that was misdiagnosed. So it's really important to make sure that their questions are answered adequately so that they can feel confident in the diagnosis of PNES. And if they are able to understand the new PNES diagnosis and develop trust, that will bode well for future treatment. It's, of course, not uncommon for patients to feel frustrated, angry, misled. They may feel distrust, or they may doubt the new diagnosis at first. So that conversation is a really important conversation to have. And we do know that when individuals accept and understand the diagnosis, they're more likely to complete the treatment and to see improvements. So once that conversation is had, and sometimes in our clinic, I will sometimes be present for that conversation to help make that transition. So ideally, the next step is that the neurologist can help bridge the treatment next step. So making the introduction to the seizure counselor or the psychotherapist or mental health provider who's going to provide the evidence-based treatment from that step on. We do find that in general, when going from a medical diagnosis to a mental health treatment provider, we find a lot of dropout in the treatment. So this is another key step, is to help bridge that gap.
Right. So you've described very well what should be happening, and it's great to hear that that is happening at U of M and at some other places. But unfortunately, this often doesn't happen. The neurologist may simply tell the person, well, it's not epilepsy, so I can't help you, or just go find a psychologist, and the patient may have difficulty finding a mental health professional who has experience with conversion disorder or non-epileptic seizures, or if they do find one, they may even be told, no, you need to see a neurologist, I don't deal with this. So what can be done to fix this problem in terms of both self-advocacy by the patient and in terms of systems change within and between the fields of neurology and mental health?
Yeah, that is an excellent question. So as you mentioned, a large proportion of mental health specialists may be concerned about treating PNES. And we do know that many are afraid that they may be missing a diagnosis of epilepsy, and so they may be afraid about treating someone with PNES diagnosis. We recommend that patients can interview potential mental health providers prior to making a commitment to treatment, because they may be able to weed out potentially difficult situations if they establish right up front with the potential mental health provider what their expectations are. So it's important for patients to work with mental health professionals who are well-informed, open-minded, optimistic, and confident in the ability of the patient with PNES to recover and to engage in treatment. So one of the ways for patients to advocate for themselves is to do things like participating in this call to learn more about PNES, to inform themselves so that they can approach the next step of treatment with knowledge. And if things don't feel right, they can move on to another provider. Another good resource is the workbook that we're using in our clinic, the Taking Control of Your Seizures workbook. That comes with a therapist guide, and one of our goals is to help disseminate knowledge about this treatment protocol because it has a therapist guide, so it can help educate mental health professionals or seizure counselors who might not have all of the knowledge that they need to treat PNES specifically, but they have a willingness and an openness to do so. So we are hoping that we'll be able to help serve as consultants to folks out in other parts of the state who may be interested in getting treatment for PNES but don't have a provider who's specifically trained in these treatments.
Is that guide publicly available, like on a website, or can it be requested from the author or anything like that?
It's available on Amazon.com, yes.
Okay. Great.
And yeah, so we recommend that patients really should make sure they feel comfortable with the seizure counselor or therapist that they choose to work with, because we know that having a trusting relationship is the foundation of successful treatment. And this workbook serves as sort of a guide to create that environment of safety where these various elements that have been talked about so far can be worked through.
Okay. And any ideas on systems change, on things that can be done maybe in medical school or on a health system-wide basis to kind of bridge the gap between mental health and neurology? To me, sometimes it seems like almost an arbitrary distinction between neurology and psychiatry.
Absolutely.
So are there any thoughts on what can be done from a broader, more systems level?
I think there are, as Dr. Winder mentioned, I think this mind-body dualism, separating the mind and the body, and as you're alluding to now, is definitely something that we're trying to move away from. We're trying to reintegrate our conception of the human body and mind. It's hard to even talk about it without distinguishing them separately, but there are pushes. For example, at our medical school, we are now training our medical students in psychological factors that are involved in physical illness. And I think across the country there are other institutions that are becoming more and more aware, and treatments like this one, I think that Kurt LaFrance has created, are a good way to help educate and eventually, hopefully, get to the level of advocacy for insurance companies to pay for these treatments. We're working on that through the Michigan Psychological Association, trying to advocate for better, more available treatment that is not separated out as either neurological or strictly psychiatric. But it's an excellent place for us to put some of our energies as we think about these problems.
Right. Okay, so we've talked about the diagnosis and causes of psychogenic non-epileptic seizures. What are the key treatment options? And we've alluded to some of them, but what are they, and how effective are the various treatments?
So cognitive behavioral therapy is probably the type of therapy that has the most research. and it has been shown to be effective. With the program that we're using, there was a multi-centered study done, and it was found that there was a 51% reduction in seizures in the patients that underwent just the workbook. When sertraline and antidepressant was added on top of that, there was a 59% decrease in the seizures, number of seizures. There were also improvements in depression, anxiety, quality of life, and global functioning. There are other treatments also that do work. Some things are very simple. For example, a new paper came out this year showing that even just offering 4 sessions of psychoeducation, that is talking about the diagnosis and the nature of the diagnosis and the disorder, that also led to a decrease in seizures and helped stabilize patients so that if they wanted to or needed to engage in longer-term psychotherapy for other comorbid problems, they were able to do that. There's evidence for short-term psychodynamic therapy as a mode for helping to reduce interpersonal problems and decreases in patient and healthcare costs with patients with PNES. And on average, the study that I found on this was 3.6 sessions, which is a pretty short-term treatment, but effective as well. EMDR is another potential treatment that is used to treat PTSD, and it's not.
Describe what the acronym is?
Oh, sorry, right. It's eye movement desensitization reprocessing therapy. And there is evidence that it is helpful for treatment of PTSD along with other treatments, but it has not been shown specifically to be a treatment for PNES. There may be patients with PNES who are undergoing this treatment because of comorbid PTSD.
And how hard is it to find practitioners who are familiar with that?
So there are more and more. There is a training institute in EMDR, and there's probably a national database from which one can find EMDR practitioners.
Okay.
Yeah. There is at least one published case report of a patient who had psychogenic seizures and PTSD, and when the PTSD was treated with EMDR, the seizures went away completely.
Okay.
Sorry, can I add one last thing?
Yeah, go ahead.
In general, as we learn more and more about what helps individuals with mental health problems improve, we're learning that it's not so much the specific therapies that are helping, it's the way that the therapies are implemented. There are certain basic elements that seem to be very helpful. The trusting relationship between the counselor and the patient, the belief in the treatment, having a way to conceptualize what the problem is, and then empathy, good, plain old simple empathy. So I think in terms of thinking about some of these treatments that are available, one of the most important things is to find something that works for the individual.
That's good to know. So, and you kind of alluded to this with the study that showed that 4 sessions of simply learning about psychogenic non-epileptic seizures often resulted in the seizures going away. How common is it overall for seizures to stop on their own once the patient learns that they're non-epileptic?
So it's actually more common than you might think. Studies have shown actually anywhere from 10 to maybe 25% of patients have them stop on their own just after they learn about the diagnosis, which is, to me, that's a big number.
Yeah. So are there, I think, again, we've kind of mentioned this or alluded to this, but are there triggers, patterns, and warnings for for PNES, just like there are for epileptic seizures? And if so, is there any value in keeping a seizure diary for people with PNES?
I would say yes and yes. There's definitely definitely triggers and patterns and warnings that people can have that is very much the same as patients with epileptic seizures. And so, you know, keeping a diary, keeping a journal are actually two of the things that are done in the treatment that we do here at the University of Michigan for our patients with non-epileptic seizures. And so it's very helpful because it's common to have, you know, memory trouble, a symptom that's often associated with this diagnosis. And when a patient comes back to the clinic and we commonly ask, so how have things been? You know, how many seizures have you had? What happened? It's sometimes hard for them to remember. So keeping a log, having it written down, and then bringing it to the appointments is actually quite helpful.
That's interesting that you mentioned memory problems. Is that primarily memory problems related to the fact that you've had periods or episodes of you know, being unconscious or unaware of your surroundings, and therefore you don't remember what happened then, or do the memory difficulties go beyond the seizure-related memory problems?
It could be both. In my experience, people often don't remember well exactly what happens around the time of their non-epileptic seizures, and that's entirely expected in many cases. In other situations, though, people may have memory problems that extend beyond just the time of the events themselves, and so that's where, you know, having those patterns and sort of trying to document the triggers and sort of the association, and then using them as your, you know, treatment in other ways can be quite helpful.
Okay. For people with epilepsy, there are a number of self-management strategies beyond medical care that can contribute to improved seizure control and quality of life, and that includes things like sleep and stress management and exercise. Are the key behaviors in people with PNES that contribute to a reduction in events and improved quality of life, are they similar, or are there different ones that you know, I didn't mention?
This is Najda. There are a number of self-management strategies that people with PNES can do to improve their quality of life, and some of them are ones that you've mentioned. Relaxation, meditation, yoga have all shown to be some good self-management tools to help reduce PNES and improve the quality of life. These techniques help because they help individuals to learn to relax their body, and this helps to reduce the seizure frequency. Good nutrition and eating balanced meals is important because it helps to maintain a stable blood sugar level, and this is important because it helps to keep your mood and energy at consistent levels. A good night's sleep is, you know, important as well. You know, whether you have epilepsy or PNES, it helps you, especially with PNES. We've talked about stress, and getting a good night's sleep really can help you to be able to handle stress, and it helps your mood. And as you mentioned, exercise has a lot of benefits for people in general, and, you know, it helps to reduce stress, improve sleep, regulates your appetite, helps eliminate fatigue, and just helps increase your energy and mood overall. So all of these different techniques are things that can be really important and really helpful.
Okay. So what's the prognosis for people with PNES? Like, what percentage become seizure-free? What's the average time to becoming seizure-free? And then also, what are the biggest factors that affect one's prognosis?
Sure. So I'll sort of interject and maybe reframe that question in a way, because I think it's actually important. I want to, I guess, emphasize that at least our approach, my approach, and that of Dr. LaFrance, who helped write the protocol that we use here in our therapy for patients, is very much not focused necessarily on remission of the seizures. Okay. And that's an interesting concept because usually everyone, and I think it makes sense, wants the seizures to just stop. I mean, they assume, and I think it's, again, correct to assume that if you were to get the seizures to stop, that your quality of life and your prognosis overall would be better. But what we focus on, and what I focus on too, is actually less on the remission of the seizures and more on function. If we're talking about this as a functional neurological disorder, well, which it's in that category classification in the DSM, is looking at how we can, enable patients with this diagnosis who may not necessarily have the seizures stop completely, still live a fulfilling and very productive life. If we look at the numbers specifically, we've done studies here at the University of Michigan in our population of patients with this diagnosis, and over the course of, looking back years in time, approximately 40 to 50% of people can be free of their non-epileptic seizures if you look back. Up to 3/4 of them are off of anti-seizure medicines, which of course do not treat non-epileptic seizures. It's actually not something that we've even touched on yet at this point, but anti-seizure medicines don't treat psychogenic non-epileptic seizures, and in some instances may actually make them worse or more frequent. And so it's important to have them get off those medicines too. Time to diagnosis is actually quite important in terms of determining the prognosis in terms of long-term outcomes and function. So the shorter the time it takes to diagnose, the better. There's some other factors too, such as younger age at onset. So children, for example, have a better prognosis of recovery and remission long-term than adults. Other things are also having a supportive family and environment, being educated about the diagnosis, and in general, in fact, education is associated with a better outcome. So it's important to understand there's lots of different factors that can increase your chances of being free of non-epileptic seizures and having a good outcome. And it's not any one thing, in fact, that means that you'll do poorly or well. When studies have looked at outcomes in patients with non-epileptic seizures, even if they are in remission from the non-epileptic seizures, there's a substantial number of people who are actually still disabled after the diagnosis, and that might be related, that may be related to other factors associated with this, but it's important to realize, I think, going back to my original point, is that although it's good to have them stop happening, we should really focus also on making sure that we can help people be as functional as possible, even if we can't eliminate them altogether.
Okay, great. So we've talked about kind of the long-term management and, of the condition, but what are some general guidelines for acute management of non-epileptic seizures, the actual seizures themselves, in terms of like seizure response, first aid? Is it similar to epilepsy? Is it different? What are some of the differences? And then also, what can family members and educators and others do to help someone during and after an episode, or if a person is showing signs that they might be about to have an episode?
So the number one thing, which is true in circumstances for both epilepsy, epileptic seizures, and psychogenic non-epileptic seizures, is just making sure someone is safe when it happens. Most of the injuries or the harm that comes from having seizures of any type, epileptic or non-epileptic, is really about the environment. So it means that if they're in an unsafe place or position, get them to a safe place and position, right? So if it happens when they're swimming, get them out of the water. If it happens when they're up at a great height, get them down to a safe level. If they're by sharp or dangerous objects, get them away from those things. And it's really about making sure that they're safe in the environment in which it actually happens. In terms of the things that, family and others can do during or after an episode, I mean, number one, it's important to know what you're dealing with. If in doubt, that there is any question about the diagnosis. If it's not sure if someone has epileptic or psychogenic non-epileptic seizures, you have to know, based upon those things, then what to do. If it's in doubt and they've not been evaluated before, or if there's some uncertainty, obviously calling 911 or going to an emergency department we think of as a safe thing to do in that circumstance. In a situation where it's known that someone has psychogenic non-epileptic seizures and they can show signs of their typical event happening or coming on, it's mostly supportive. So being there, making sure that, again, they're safe, making sure that they're, not in any acute distress from what's happening in the environment to the best of your ability, making sure that you also don't overly coddle, and that may sound bad, but we do think about these non-epileptic seizures in different ways. We certainly talk about them as being caused by underlying psychological conflict. And in some ways, we don't want to really encourage the behavior. And it's, again, not something to say that these are things patients are intentionally doing, but rather it's something that we can try to not reinforce the actual events themselves. And to do that, we have to give space. You have to let the patient experience the symptoms that they're experiencing, and hopefully let it pass as it will naturally with time, and make sure you're there to support them, when it passes, and doing whatever you need to do to help.
Okay. And are there actually situations where 911 should be called, even if you know that they have psychogenic non-epileptic seizures? I imagine injury would certainly be one, because injuries can occur, just like they can with epileptic seizures. But are there other situations where it would be appropriate to seek emergency care?
Yeah, you hit the number one thing. I mean, certainly if there's an injury, that's probably the most urgent thing to address. But if you are concerned about the patient, if they are unresponsive for a very prolonged period of time, if they have, the symptoms are lasting longer than usual, if they are continually having the symptoms on and off, and they don't seem to be stopping, and it's not following a typical pattern, those are the things that you have to look out for. Clearly, if the event is different in some way than what their known non-epileptic seizures are, it could be a sign that there's something else going on, because obviously it's possible for someone with a non-epileptic seizure to have something else happen, right? We know that a substantial number of people have epilepsy too, and it's possible to have an epileptic seizure, and it may be different than a non-epileptic seizure. It's also possible that people with psychogenic non-epileptic seizures could have other medical symptoms that happen, right? Like low blood sugar in patients with diabetes, or stroke that can cause neurologic symptoms. Patients are at risk for everything, just like everyone else is, so it's important to recognize when those things are different than what usually follows course.
Right. So what are some of the common challenges for people with PNES in daily life and interacting with others, such as family or friends or coworkers or employers, and what are some ways to address some of those challenges?
This is Najda. A common challenge for people with psychogenic non-epileptic seizures is a lack of understanding by family members, friends, coworkers, and really just the general population. In general, people have a common understanding about what epilepsy is, but not what PNES is. And some of this Nick and Lisa and Scott have talked about, with people thinking that it's something that they're faking or pretending, or something that they've got the control and are just doing at that moment. So part of it is educating people. Additionally, because PNES is defined as a psychiatric illness, there's also stigma associated with it, as there is stigma around mental health diagnoses in general. So some of this can be addressed by educating family, friends, and coworkers more on what PNES is. And part of it, too, is about people who have this deciding how much information and detail to give to people. For instance, instead of giving all the details to a friend of having PNES, someone could say that they have seizures without going into the specific diagnosis. Right.
Okay. And because of the public's lack of understanding of PNES and common biases that arise, is it perhaps more difficult than with epilepsy to get Social Security disability benefits or accommodations in the workplace or other benefits that are typically available for people with disabilities? Is discrimination more likely?
Yes. Unfortunately, for people with PNES, Social Security disability benefits are harder to get because if they there are some patients, as we've mentioned, that have both epilepsy and PNES. But if someone has PNES and not epilepsy, then for Social Security disability, they look at it under the mental health category. And in general, trying to get Social Security disability benefits under mental health is a lot more difficult than under other categories. However, it is possible to receive Social Security disability benefits with PNES, but it is more difficult. And there are workplace accommodations that people with PNES have the right to get, and these ones are things that are legally protected through the Americans with Disabilities Act, and this also protects them against discrimination. And for PNES, with Americans with Disabilities Act, it falls under psychiatric illness and protections there, and they can get reasonable accommodations. And these reasonable work accommodations vary depending on the individual and what they need, but it's about things that would help to support them to increase and maintain their job performance. Some sample accommodations can include things like a flexible work schedule or start time, being in an area where there's reduced distractions, the possibility, depending on what their job is, about working from home or telecommuting, having flexible break schedules and a quiet place to rest during a break. And to receive workplace accommodations, the first step is to make this request through the employer's Human Resources Department, then decide on the type of accommodations you need, make this request in writing, and also talk with your treatment provider to provide a letter supporting these accommodations and get these to the Human Resources Department.
Right. Okay. Great. Well, we're going to go ahead and open up to questions, and I appreciate everyone's patience. We had a lot to cover here. Okay. Does anyone have a question?
Hi, my name is Tony, and I was just diagnosed with nonepileptic seizures August 28th, but I also do have epilepsy. So what I wanted to find out is, because I have epilepsy, I worry a lot about having a seizure in public. So will that trigger the non-epileptic seizures more?
That's a good question. We talked earlier a little bit about how stress is actually one of the most common reported triggers for epileptic seizures, and I think it falls likely that stress could be a trigger for non-epileptic seizures too. So I think that if you think about the different ways that you could try to approach your seizures, knowing that you could have both epileptic or non-epileptic, if you worry about your thoughts and how your anxiety perhaps about having a seizure, no matter what type, could have an impact, then potentially getting treatment focused on the way in which you think about your seizures could be helpful, which is a lot about what we do in our treatment for patients with non-epileptic seizures. It's interesting to note that the protocol that was written initially by Dr. LaFrance and others that we use for our patients in our clinic was actually intended originally for patients with epilepsy for use in trying to reduce stress as a factor that increases the risk of having an epileptic seizure. Dr. Patterson, do you have anything to comment about that?
I think I would just support everything that you're saying. I don't think I can add anything much more to that at this moment.
Sorry to put you on the spot.
No, that's okay. I wanted to ask a personal question, but I don't think that's appropriate in this venue, so to help. But maybe we could talk offline if that's an option.
Yeah, sure.
Okay.
Just one more thing. I had for 7 hours straight both epileptic seizures and non-epileptic seizures. So should I stay home or go to the emergency room? Because I was told by my epileptologist to just stay home and let the seizures just stop by themselves. But then after hearing what you've had to say, I can't remember the doctor's name, I should go to the ER?
So it's hard to give advice, obviously, in this kind of a context, not knowing what type of testing you've had in the past. But in general, if you know that you have one type of seizure that's epileptic and you have another type of seizure that's non-epileptic, if you can tell the difference between the types and you know reliably that one is one type and one is another, then in general, a patient that has regular or very frequent epileptic seizures over a long period of time, that may be a reason to go to an emergency department or call 911. It's not universally, however, for patients with epilepsy, and in some cases people do have frequent epileptic seizures, and there's obviously a cutoff. You can't always go to an emergency department every time anything happens. You have to use your judgment, and I think that the judgment is really both between you and your epileptologist together. I'm sure that there's more detail beyond what we've spoken about, but I would say, use the advice of the epileptologist that knows you best. We always get concerned as neurologists if a patient has an epileptic seizure that's prolonged. The standard is that if they have a convulsive epileptic seizure longer than 5 minutes, or if they have more than one back-to-back where they don't return to their normal level of consciousness, that they should call 911 or go to an ER.
Right. So I think the key thing there would be, just learning, if you don't already know, how to distinguish between the non-epileptic seizures and the epileptic seizures, which may not be straightforward for everyone, but that's something that I think should be a goal, to be able to tell the difference between those and have friends or family members or anyone else who's supportive of you know how to tell the difference as well.
Yeah, I know how to tell the difference by now.
Well, Russ, maybe I could just add one thing. I mean, one thing that I think about with folks with complex and interacting sort of psychiatric and medical conditions, and we might say that these types of seizures, the non-epileptic seizures, we could think about as psychiatric just to distinguish them, and then the epileptic seizures being medical. One of the things that mental health doctors work with patients with medical issues a lot on is avoiding activity limitation. Many people with pulmonary disease or neurological conditions, or who have been disfigured in some way, maybe in an accident, will avoid going out in public because they fear some reaction or they fear some recurrence of symptoms, and with good reason. It's not like that's not a reasonable assumption. But what happens to people emotionally is when they isolate themselves, and when their sphere of their life, like where they go and what they do, gets limited and becomes smaller and smaller, that itself can lead to emotional problems because they're thinking about what they'd like to be doing or how their life used to be. And so it's not to do something unsafe, but oftentimes mental health tries to encourage patients to accept that there is a risk, to have a good plan in place, to know what to watch for, and to be confident, and to try and push against that tendency to isolate and to stay home and to be fearful all of the time. And that can have profound benefits both emotionally and medically as our activity increases.
Great point. Okay.
I'd like to say something.
Go ahead.
This is Jacqueline.
Go ahead.
Hello?
Yeah, go ahead.
Oh, whoever just spoke, I really, really appreciate what you just said. I have psychogenic nonepileptic seizures that was diagnosed when I was pregnant with my first child. I'm not pregnant with my third. I get, they tend to be triggered by any kind of stress, maybe mental, physical, something as simple as maybe walking 10 minutes might put me into one. And it's difficult for me to go out with my family, social settings, or to store, grocery shopping. I didn't hear anything. I heard Social Security disability, but I didn't hear anything about how I would go, or people with this condition would go about getting a handicap stickers or validations, because I know maybe just going grocery shopping 30 minutes in the grocery store is about what I can take. And then having to walk all the way back to the parking lot is even more. It just adds to it. So in your experience, has there been people who do get handicap validations, or how would I go about finding out more and applying for that?
This is Najda, and I can address kind of the how-to. In order to get a handicap sticker, there is a form online for the Secretary of State that needs to be filled out. It needs to be filled out by a physician, so that would be something that I would talk with your epileptologist about filling out. It's a pretty simple form, but you would need to have it filled out by a physician and then taken to Social Security, taken to Secretary of State.
Okay.
I can say that from my perspective as a neurologist, this is Nick Beimer. I've never actually had a patient that thought maybe that would be something that would help, but I agree with you that if you recognize that there are certain features that you know are reliable triggers, part of what we try to work on is what are things that we can address and change potentially in terms of triggers, and what are things that we can't. Because there are, unchangeable things about life. But if it's a simple thing, like just having a disability placard in your rearview mirror so that you can park closer, walk less, get your groceries and get home, personally as a doctor, if a patient asked me for something like that, I would be in favor of it. I've never actually had a patient request that before, though, in my experience.
Okay, I won't mention any names, but the person I'm currently being seen by will not give me one because he said it's not physical. It shouldn't have anything to do with what's going on. So I would just work on perhaps finding someone who would accommodate that.
Yeah, I would be in favor of it personally. There may be other reasons. I'm not sure, or I'm not aware of what those other reasons would be, but I agree. If it's something simple like that, I would be in favor of it personally, if that were the case.
I don't want to take up all the time. If I wanted to know more information about the work you do at U of M and how to be seen as a patient, who would I be able to ask those questions afterwards?
Sure. Ask Rust. I would say, Rust, could you give information about, referrals? I know that you've had a couple of other patients you've sent to us.
Sure. Yeah, I'd be happy to help with that.
All right. Thank you very much.
Okay, maybe time for one more question, and then we have to wrap it up. Okay. Well, we're going to have to wrap it up, but I do really appreciate all of our panelists staying on for more time because it's such a complex topic, and it's really important to cover it. And I really appreciate everyone participating. And again, if anyone has any follow-up questions, please feel free to call me, and I'm sure the panelists I can relay those questions to our panelists, and they'd be happy to respond.